Executive Director of the African Health Economics and Policy Association, which we all call AFIA, dedicated to strengthening the capacities of African health economists and policy experts, as well as financing and policy in health sector decision-making in Africa. So at the invitation of the Ghana Public Health Association's president, Dr. George Amofa, Dr. Chris Atim accepted to present at this scientific session on resource mobilization for public health. Ladies and gentlemen, we are welcoming now Dr. Chris Atim to do his presentation. Dr. Atim, you are welcome, and I think you now have the floor. You can share your slide and do the presentation. Thank you very much.
Thank you so much, Dr. Senior. Am I on both video and
Yes, please. I can see you. You are on video and also, yes, audio.
Sorry, I'm having some call coming in. Yeah, okay, thank you so much. Really appreciate that. Yeah, so thank you, Chairperson, Madam Chairperson, and to the Ghana Public Health Association for your surprise invitation to me. I was really surprised. I got an invitation to make this presentation to your members. And I feel humbled about that. And just to say that Dr. Mofa and others, when they got in touch with me, they were very generous. At the invitation letter said I could take any angle that I wanted, and they were not restricting me. So I really appreciated that, because then at least I could use my imagination and decide what would be probably most interesting and useful to present. So thanks for that consideration. I should also say that just right off that I really appreciated support from my colleagues in R4D. The Ghana R4D team is really a dream team. I mean, say all of them. And I just want to mention that Ajwa, Katie, and Tayo really were very, very helpful to me in the preparation for this. So I want to give them a shout out at the beginning of this. Thank you so much. You're really wonderful colleagues. And then I know we have just about an hour or so, and I don't want to abuse your patience and so forth. The time is going to go really fast, despite everything. I was afraid, in fact, that I would actually be sleeping by this time. I ate yam at this, lunchtime. I'm really feeling very drowsy. So glad to be, that didn't happen. But just bear with me if anything happens when I start sleeping. Okay. So for introduction and scene setting, I'd like to start by looking at why resource mobilization is important. For your members, the GBHA, I believe that some of this is really just simply setting the scene, not really providing any new information. But I think it's important to go over some of these ground issues. Also partly because I know that some people, contacted me and said they were joining who are not really part of the association or even professionals in this field and might actually benefit from some, basic explanation of some of the, issues. Yeah. Excuse me, because some people are not having difficulty joining, but I can't really do much about that. I'll just turn off this phone. Yeah. And then, so I will look at some of the basics, including, why public health, the financing for public health is it's more problematic than for other areas in health, because that's really the core of the issue and why I know I was invited to give this presentation. And then I will spend quite a bit of time looking at how countries mobilize resources globally, and look at what opportunities and issues arise there. And in particular, as why the WHO and health financing experts globally, have latched on a particular method of resource mobilization that they recommend to all countries, more or less. Then, and we know there's an increasing emphasis on domestic resource mobilization. I look at some of the factors behind that, and then zero in on the African health financing trends, and of course, then come to Ghana. And kind of look at the application of all of that to our Ghanaian health financing scene and mobilization of resources going forward. So what's resource mobilization and why is it important? As the chair said at the beginning, right at the start, you can't really undertake anything without resources. So that's really the main driving factor behind this issue of resource mobilization. It is a process by which countries raise and spend funds to finance their health activities. So raising the funds needed to pay for the health services and programs that they have. But this is often, I mean, perhaps not given the same attention. It also includes making better use of and maximizing existing resources. It's not only new resources, but it's also how do you use the existing ones more efficiently. And the objectives from the point of view of the health sector are really to raise sufficient funds and revenues to deliver all their health services, also to enable continuous or sustainable provision and improvements and scaling up of services for the population, to meet the growing needs and cost escalation in health. Cost escalation is a fundamental, more or less fundamental law in all health systems worldwide. There's an exception where cost escalation isn't a present issue. And particularly for the developed countries, their issue is not raising resources as much as reining in costs. And we are moving in that direction as well. So we have a twin problem. And that's an important element in resource mobilization. And then this one, the last one, actually it's a very key issue. The resource mobilization, in fact, is actually partly because we want to ensure that the resources are pooled, resources for the sector are pooled in such a way that they enable us to do things that we wouldn't be able to do if we didn't mobilize and pool them together. So strategic purchasing, in other words, you want to make sure that when you have the resources available, you can direct them, allocate them in such a way that you purchase or you're able to get when you allocate them, you get the results that you want. It's not just simply passively allocating them out for inputs and salaries and so on without asking for results. So strategic purchasing is really only possible if you can pool the resources. And that's a key reason why resource mobilization is an important aspect of health financing and the health sector in general. So what are attributes of a good mobilization approach is? They should be easy to collect, obviously, predictable and stable, so they can meet growing needs. We don't want that you plan that you're going to you're going to have this amount of money at the beginning of the year. At the end of the year, you have far less than what you actually predicted or you actually planned for. So that's important. The sustainability, integrating well with well-aligned public financial management systems, PFM. It's actually important. Even a very good public financial management system actually is also a resource mobilization tool in itself, because a very good PFM, as we call it, system will liberate resources that often get wasted. So, and I'll talk about public financial management systems like GIFMIS, Ghana Integrated Financial Management and Information Systems that the Ministry of Finance is trying to get all agencies to use. And they actually found out that some agencies were not aligned with that. So when they are not well aligned with it, then it's difficult to get efficiency, the efficiency gains that are intended. And that's a waste. Then equitability and fairness in the generation of revenue. You don't want that in the process of actually generating the revenue, mobilizing it, that you actually impoverish people. So, and you also want to make sure that those who can have more means pay more, and those who have less means pay less. Non-distortionary is actually concerned mainly of the Ministry of Finance, but nevertheless important for us to know that, because when we propose methods of raising funds, we should be aware how the Ministry of Finance will react before we even go there, and not get told that this is going to just distort our economy, it's going to discourage production, or other beneficial economic activities and so forth. So it's good to know, and that the method should be aligned with our USC goals and ambitions, which actually encapsulates some of the issues about. So a resource mobilization, they used to call it revenue raising. Nowadays, in modern time, resource mobilization, because it's broader, but I use them interchangeably. And it's part of health financing. So it's one of the three functions of health financing. The other one is being pooling and purchasing. And here, this I can just simply showing that, your resource mobilization as part of health financing, is linked to the USC goals that every country is now pursuing. and in the ways that are shown here, with intermediate objectives and final goals. So what we are undertaking is actually part of that process of trying to achieve UAC. So where do we mobilize revenue from? In general, there are these methods. Domestically, general and earmark taxes, social insurance, private insurance, community financing, including mutuals and mutual health organizations, out-of-pocket payments or user fees. That's the one least recommended. We'll come to that. The private sector investments as well contribute to the sector, and external assistance. Now, if you know that companies pay for their employees sometimes, you may consider that as either private insurance because that's self-insurance, or where if you think they are investing in their employees, you can put them on a private sector investment. But that it's capture all the methods that we know of. There's a challenge in particular. Now, this probably comes into the crux of our issue for today. There's a particular challenge in financing public health vis-a-vis personal clinical care, which is delivered at fixed delivery points. What is this challenge? There's a dilemma. Now, on the one hand, the cost effectiveness of public health investments is not in doubt. Everybody knows that because public health investments are very cost effective. You just have to look at the disease control priorities, periodically issued. You can look at publications in the Lancet, meta-analysis and systematic reviews. It's all very clear. So I've not even bothered to present the evidence here because it's well known. It's very cost effective, very much so, than curative care, for instance. But the curious thing is that individuals, people are more willing to pay for personal clinical care, right? Even though they even pay out of pocket for, obviously, often, clinical care is often life and death issues. You would be willing to pay for that, okay? Even though out of pocket payment is not recommended, as I said, due to inequity and inefficiencies involved in that. On the other hand, nobody wants to pay for public health, which is defined the art and science of preventing disease, prolonging life, and promoting health through the organized efforts of society, And it covers interventions that are focused on populations rather than individuals, including preventing, promotive, and even some curative care, as mass treatment. But the delivery platform here being usually community rather than fixed facilities. I'm paraphrasing and often involves working with other sectors, right? Water, sanitation, public hygiene, in order to address wider determinants of health. And also with health professionals. Particularly, it's well known that primary care professionals, primary healthcare provision can play a key role in preventing illness and promoting health. So they are a key category in the promotion of public health. Now, in economics, this dilemma we're talking about is often called the challenge of paying for public versus private goods. Okay, public goods, the goods which are collectively consumed, or socially consumed, which is difficult to charge someone for. Roads, sanitation, some things like that. If you provide them, everybody can use them normally, and you can. And you can't prevent really users, people who access them, and people who use them, even who uses that good doesn't, as it were, prevent anyone else from using it. So, now public health interventions are closer to public goods. Now, they are not all perfect representations of public goods, and even when they are not, public goods as such, they are actually merit goods. Merit goods being those that society wants people to consume or to take because they promote health and well-being, but which the free market will not provide, adequately. So you actually require public intervention to be able to encourage people to use them. Maternal and child health, for instance, services are very good examples of merit goods, and even if they are consumed individually. So public health interventions really, have these aspects, and yet they are the ones that individuals tend to be prepared to pay for. So the classic solution to that is to use public taxation to pay for them. And so you'll see that there's a tendency, for instance, for premium-based insurance systems, such as our NHIS, to focus frequently on curative care rather than public health interventions. which can lead nevertheless to misallocation of resources, or at least to underfunding of critical interventions, and which is a problem actually we are facing. I think that's the crux of the problem that we are going to discuss today. Okay, one advantage of the social insurance systems is that they tend to command wider public support than the tax-based ones. People don't see them as a welfare benefit, but rather a benefit indirectly from their contribution to the scheme. You just have to look at continental Europe, see that those systems are very, very popular among the public. No government wants to attack them. Tax-based ones tend to have less support. I mean, the UK often has a lot of problems with the tax-based systems, but nevertheless, they are the ones that actually have broader benefits as far as public health interventions are concerned, and other effects such as efficiency and so on. So there is a kind of tension there. Now, a World Bank study found as far as I can identify that a lesson to be learned from high-income nations is that when fiscal power over health insurance is concentrated in social or private health insurance schemes, the health ministry has limited influence on the allocation of healthcare resources. And as a result, preventive services may become underfunded. Now, does that sound familiar to anybody here? If you go and ask the Ghana Ministry of Health, they would absolutely say that this is very, very true. Because with the setting up of the NHIS, their influence over the allocation of resources has diminished. And that's the dilemma. Publicization is nevertheless the most sustainable and equitable source of funding public health. And due to the public goods agreement I just mentioned now, the priority for the use of public taxes usually should go to public health interventions. That's the received wisdom, and it is actually one that is soundly based. But then, as in Ghana, where funding is increasingly being allocated to NHIS, I'll show you a graph later on that shows that funding is actually, or a chart shows that funding in Ghana is increasingly being allocated to NHIS, so detriment of other public health funding. How do we adequately fund public health priorities in that context? So we'll come back to this towards the conclusion. I will leave that hanging there for now. Some additional insights from the research and experience on health financing over the decades. One is that the tendency of low and middle income countries to underfund public health interventions is a driving force behind several of the international initiatives that we see, like Gavi, right, for vaccinations. The funding by private foundations like Rockefeller, Bill and Melinda Gates Foundation, they're actually intended to help address those gaps. Now, the key issue is not only how to mobilize resources for health. I want to really emphasize this, but also to ensure that these resources are directed to their most cost-effective uses, which I think Judge has been trying to argue in a typical country like ours, includes public health. If we use public cost-effectiveness criteria for allocating our resources, there's no doubt that public health would not be suffering from underfunding as we're seeing now. Unfortunately, that's not always the case. And so we have that dilemma. Now, when we examine country health expenditure or funding sources, so I want to emphasize this, we should pay closer attention to the public and not the total spending on health. I will show that soon, again, with some charts. And there's also a point, even the countries that have historically relied heavily on premium-based contributions, Germany, France, or payroll taxes in the past, have tried to mix this with general tax-based funding in the course of time. Often it's through deficit funding, deficit financing, or simply putting the beneficiaries on the budget, the schemes on the budget for supporting some of their costs. Belgium is probably one of the classic examples of that. Now, another insight that we should keep in mind is that countries that see growing GDP in the course of time. Sorry, Regis. I have to apologize for this. I'm turning off my laptop. Those countries that see a growing gross domestic product in the course of time also tend to see an increasing health sector resource envelope. That's especially a public spending component, all other things being equal. And I will show that as well. So, and these are insights that we that come from their experience. And so they give grounds for some hope, I think, at least this last point. So how do countries generate revenues for health? Let's see. Financing sources by country income group. Here we have the lower middle, upper middle, and high income countries. How they fund health general. You see that domestic public, which is the green, is generally growing as the country gets richer. It is, the domestic public begins to crowd out the other elements, voluntary health insurance, aid, out of pocket, whatever. They always get smaller, and the domestic public gets bigger. So that is already, and I mean public funding, right? So that's a sign, that's already a very good sign that we see. But this is for 2015. However, even if you look at longitudinal data, this is over a period from 2000 to 2015 for the same countries. So more, time series, you find that it is indeed still true. However, this is more interesting. The low income countries actually were seeing decline in domestic public funding. That's the blue again, the bottom ones, are seeing declines over the period. But there was a substitution effect going on. The external aid was making for that. Remember, that's the period, the 15-year period with the MDGs. And the express compact of the MDGs was that the more advanced countries will support the low-income countries to achieve the targets that were set up in the MDGs. The result was what? Well, some people say low-income countries, so decline in their actual tax revenue for health, which was made up for largely by external assistance. Low middle income countries, very similar. They didn't actually see sharp decline as such in the funding, but we can say that it was more or less steady throughout that period. And they also had some funding, external funding, that enabled them to actually have a gradual increase over time. The effect that we saw in the previous chart is still correct in the case of the upper, middle, and high income countries. They are seeing continuous growth in the public sector component, the domestic public of funding, to the detriment of the others. So this is true whether we are looking at it, we are looking at it over time period, like the 15-year period we're talking about, or not. This is a general fact, and that is a good, I think, observation to give us hope in the sense that as we move further and our economy grows and so forth, the future is bright. In effect, that we can expect there will be more public funding available for health. Now, to continue that, look at some of this in more detail. So the systems of financing and payment in some selected high-income countries. You see that the countries on the left, these are OECD countries. In general, we will not just ignore Singapore for now. It's a very special case we were not going to talk about here. If we're interested in talking about Singapore, we can talk about it later on. It's a very special case. But nevertheless, look at countries, general taxation. In the case of Canada, not just general taxation, but also central and regional government contributions. That's an interesting one. But that Canada, Sweden, and UK, all really rely on general taxation. I'll show the effect of that. Some analysis of how the impact of that just in the next slide. The other countries which depend upon health insurance, classically speaking, France, Germany, Japan, and so on, they actually mandate the social insurance. Okay, it's actually a mandated system, and nearly all of them use a global budget just for maintaining for containing costs, more or less. Again, with the exception of Singapore and even Korea in this case. But nevertheless, and of course the United States is always a special case too. So so general taxation is really the financing method that is most prevalent in those countries, or in some of them, plus mandated social insurance. And you can, there's some context in which people think the mandated social insurance as part of taxes actually is often based on payroll taxes. And payroll taxes are different from general taxation, or at least income tax. but nevertheless, it's taxes. Now, look at, so that distinction now enables us to see what the impact of different funding methods are on equity, cost control, and efficiency of resource use, and even consumer choice. And what I just want to show here is that you see that the general taxation countries, like the classical general taxation countries, what is UK, Canada, and Sweden, which is not actually mentioned here, but Sweden is one of those countries. It's basically Scandinavian countries, you can say. They actually score the highest on the criteria of, on this criteria. These are intermediate, remember, factors, intermediate objectives that we saw in when I was talking about the link between resource mobilization and the USC goals, your intermediate goals, were these ones. So equity, they score highly on equity, whether in access or financing, cost control, the efficiency of resource use. Somewhat lower on consumer choice. I think on consumer choice, and that's a well-known phenomenon, the social insurance countries, this is why they're so popular, by the way. One of the reasons why they are very popular with the public is that their consumer choice is higher. But otherwise, on the other criteria, they tend to score somewhat lower, than with general taxation. So that's just to give you a measure. By the way, we belong to the social insurance category. Although we have a mixed system, I should correct myself here. We have a mixed system, not mixed in the sense of the bottom line, but mixed in the sense of between general taxation and social insurance, because we have an insurance mechanism, but it's funded by general taxation in effect. The VAT is a general taxation. So that we have a mixed system, which is better, I think, than just the social insurance or the mixed ones below there. The mixed ones below there definitely score the lowest in terms of these criteria. So, okay, so we made a point that, really the revenue should come from general taxation. If we want to mobilize resources for public health, it should come from general taxation. And that's, a conclusion that comes from all the analysis of, what is the most efficient way, equitable way to raise resources to fund your health system. And we made a point that, the taxes, it is easier with mobilized practice through that method to also fund public health interventions, whereas it's more difficult if it is, if you raise them through social insurance, classical method, payroll contributions, that is much more difficult. That's not usually how social classical health insurance systems are actually are designed. But and I should also mention, I didn't say at the beginning, this previous slide, this is actually the classical representation, but even the countries in the social insurance category, and just like Germany and France and so forth, have moved in the course of time to actually embrace elements of the general taxation. As I said, they use general taxation to actually supplement the cost of insurance, because the individuals cannot be expected to bear the burden of a cost escalation in health. As I said, cost escalation is a fundamental law of course of health systems, and classically, if the insurance system makes its money by, remains in balance by calculating what their costs are going to be the next year, and then dividing that by the number of members, crudely speaking, and if you did that, the burden on individuals will be just too great. Nobody will be able to, people will be an outcry. So by force, especially if you're a democratic country, essentially there has to be a subsidy. So governments are subsidizing, the insured population. So how much should we then mobilize if that's the case, and spend on health? Now, there isn't a magic number as such. We have some normative benchmarks and targets. For instance, let me just begin with the out-of-pocket one. The out-of-pocket, WHO recommends that out-of-pocket expenses, in order that individuals in a country would not be impoverished when they go to spend, when they are sick, they have to go to health facilities. The country should, people should not pay, as a proportion of the total health expenditure, the amount coming from out-of-pocket expenses should not exceed 15 to 20%. That's a WHO kind of norm or benchmark. Here, you will find that Sub-Saharan Africa is averaging 41% of total. So we are actually bad, and that's only because actually some countries are actually much lower than this, and I mean it's an average, you can imagine. So there are countries that are much higher than this. Countries like Nigeria, Guinea, really about 70%. It's really incredible. We're not terribly good ourselves, but we're below the average. I will come out. There is one a format of this I will use for Ghana when I come to talk about Ghana. So you will see where we land on this. Then the Abuja Declaration. Now, Abuja Declaration is a interesting topic often for me because I have now that the recommendation that countries should spend at least 15% of their budget as like on health, which is we all know. When this was suggested, initially suggested at Abuja summit, called by Obasanjo at the time, it was actually linked to achieving certain targets. It was actually linked to achieving the targets related to HIV, AIDS, TB, and malaria. When they actually moved it, that was that was what the summit was about. In fact, the summit was on those the achievement of those targets. Now, this has mutated, or evolved in time to become the norm that countries are supposed to follow in order to be able to show their commitment to health, health achievements. Now, I have taken issue with that because now as a financial target, that's fine. If it is a financial target that shows that says, look, we want the country to spend this amount as an indication of their commitment, their effort. That's fine. However, as a target, as an amount, or a target to be able to make advance or progress on achieving health targets, it's actually a misplaced priority. It's a misplaced target or a norm, because like all ratios and percentages and so forth, everything depends on your denominator. And the reason what piqued my interest when this happened initially, the first tracking that was done by WHO Afro, as soon as this declaration was made, the first tracking they did, I looked at it. There were 4 countries in Africa that actually achieved the target. Every other country hadn't achieved it. Just in the first, I think, was around 2004 or so. 4 countries, and among those 4, there were 2, DRC and Liberia, which were in civil war, and therefore, the 15%, having achieved 15% target didn't mean anything to the populations of those countries. It was simply what happened was that because they were in civil war, the economy had contracted drastically. But because of humanitarian assistance and so forth, actually spending on health was relatively better than on other areas. Of course, it was very, very bad, very, very bad. And people were just not getting, these facilities. So it was really ridiculous that it showed that the best performing countries on this target were countries that were in civil war and were not actually, and where the population would be actually very outraged to hear that they were doing well on health than, say, a country like Botswana and Mauritius, which had the best health indicators at the time, but were spending less than 15%. So it just didn't make sense. So actually, I had opportunity when I was working at Apple Associates to do a study with some colleagues for the African Union, the Minister of Health meeting in 2009. Actually, was the author of a paper that presented at the technical meeting of the Ministers' Conference, in which actually argued that this was not an appropriate target for tracking performance on health achievements, but it was still useful as an indication, as a financial target and an indication of the government's commitment to the sector. And so long as that was how it was viewed, that was okay. But I also argued that a more appropriate target to track, which they actually accepted, that technical meeting anyway accepted, was that was the one on the bottom right, the WHO World Bank Forum on Health Financing target of $86 per capita. At that time, it wasn't $86 per capita. It was a different. It was actually, the target was a CMH target, not this one. The Commission on Macroeconomics and Health had a target of $30 or so dollars per capita, which was very, very low. Low now, but in current dollars, therefore, it had to be. You have to update that. And that's the reason why, you know, this was updated. Even this update was still low. In my view, this $6 per capita is low. You know, it's really low. But nevertheless, this was the one that most recent one that an international forum recommended. So $86 per capita, you know, because that tells you at least how much is available for purchasing healthcare for your population, the amount you're prepared to spend per capita, especially if the dollars are PPP dollars, which in this case they are not. So, you know, the African average here is $29. So very far below even what is recommended. And then another one, which is emerged in the context of the UHC agenda, is that countries should not spend less than 5% of their GDP also on health. Yeah, Africa is pitifully at 1.5%. But this GDP, I just want to remind you that actually 5% of GDP is probably just the barest minimum for the barest minimum package, because the countries that have achieved UHC are spending between 8 and 12% of their income, of their GDP on health. So which actually this is well below, but nevertheless it was, because it's, you know, it's a progression. It's supposed to be a target that low income and low and middle income countries are supposed to work towards. And given that we're at a very low base, so even getting to 5% is, you know, a great thing. But nevertheless, we should not be under any illusion that 5% of GDP will give you a very expansive package. It's the point I'm trying to make here, you know, but it will be progress if we can get there. So, so now, okay, there's an increasing emphasis on domestic resource mobilization. There are factors, many pressures behind that, as I show here on the left. You know, the low spending per capita in our countries, which the pressure is itself a factor. You can look at spending per capita in low-income countries, $32 per capita compared to, you know, LMICs and HICs, high-income countries and lower middle-income countries. The external resources represent currently, actually, despite all the noise about external aid, it usually represents a small portion of the total health spending, even in those countries. You know, below 30%, in the low-income countries, and minuscule in the others. There's a need to shift away from out-of-pocket spending. This is highly regressive. Also, I think the one key thing about out-of-pocket spending actually regards to the point I made earlier about resource mobilization being a tool for strategic purchasing, and needed to be, therefore, needing to be pooled, you know, in order to be able to achieve that. That the out-of-pocket spending or user fees are precisely the only tool that does not permit pooling. And so that, for that reason alone, it's just actually not appropriate as a means for funding your healthcare. So there's a move to remove user fees. And the need for predictable and sustainable financing. And then the last one, which is the international context. As I said, the MDGs had a company where basically had an underlying compact, which is that the advanced countries will support the less developed ones in order to be able to achieve the targets that were spelled out. With the SDGs, that pact has been revoked. Now, the lying assumption is that countries would use their own resources, and only in the case of low-income countries, the poorest countries, those in fragile, you know, situations, that the advanced countries will support them to achieve some of their targets. But nevertheless, the fundamental basis of the SDGs is that countries will rely on their own domestic resources. So that's a great movement towards the use of, domestic resources, not to fund healthcare. By the way, if anybody is looking at the out-of-pocket expense as percentage of private health spending here, you may be shocked by these figures. Actually, out-of-pocket spending here, we're not talking about the total health spending. It's not a percentage of total health spending, but private health spending. So what this means is that private insurance, because private health spending is made of what? Made of out-of-pocket user fees and private insurance. Those two make up private spending in general. So other things, but they are minor. So what this means is that private insurance is not well developed in these countries, bottom there. And so a high proportion of your private spending is actually out-of-pocket spending. So I don't get accused that after all this talking, I've not mentioned any domestic financing methods that can be pursued. I just present here some methods. I mean, there was a time a few years ago when the literature was all full of innovative financing, lots of workshops that were held on innovative financing. Actually, I borrowed that language, but put it in quotes because I don't really believe there is anything innovative about any of them. So there's a lot of hoopla, but so I just mentioned some of the methods that I use classically, giving examples. So the type of tax, heritage taxes, for instance, and taxes on large companies and windfall profits. I was involved in a mission to Guinea when I was, working at the bank, and they had just got $700 million windfall profits from bauxite mining, and they were kind of discussing what to do with that. They wanted some support to invest. And actually, my role in the mission was to help them to come up with health proposals, health sector investment proposals that could be included in the decisions. So heritage taxes, windfall profits. There are countries there that are using so companies in mining, oil, gas, and other natural resources, tourism, mobile phone companies. Now, even the IMF recommends that the first target for raising taxes, if you want to, should be that top one, the heritage taxes and taxes on companies and windfall profits. But you find out that perversely, many of our countries actually have tax subsidies or tax exemptions for these companies. So you ask, why on earth do you have a tax exemption for, say, a bauxite company or a gold mining company in your country? I mean, it's not as if you say, you are going to pay tax, they are going to get up and take your mine along. I mean, the mine will still be there. So it's kind of, it is perverse. It's very recommended, it's highly recommended that you actually do not do that, but you actually look at it as a potential source of raising resources. Taxes on goods and services, usually, we talk about sin taxes, so on, currency transactions, debt financing, also methods. And I've given examples there, of countries that have used those methods and some of the amounts of money they have been able to raise through that. So now come to Africa. I think I'm spending too much time on some of these things. I'm trying to go a bit faster now. Resource mobilization in Africa. So financing as a percentage of current health spending, right? So that's all goods and services except capital spending. Yeah. We'll find that some number of African countries here. Ghana is at the bottom there. Not at the bottom, not because it's the least. I'm just saying that it's at the bottom in terms of the order here. That is not ordered on any particular. It's not a normative or an ordinal system here. So we have, if at all, the other countries are far worse than Ghana in terms of the distribution. So we have domestic public, which is the green. But we'll tease out here social insurance. Social insurance is actually part of the domestic public. But we'll tease that out here just to show what the role of social insurance is for the contribution here. So you'll find that is the light green, the social insurance. And then you have the user fees, which is the black, external assistance, and the voluntary insurance, the yellow. And so this is quite a varied picture. So what do you make of it? What is, what's remarkable perhaps here is how Nigeria is so much dependent on user fees, a huge amount of user fees, as well as Equatorial Guinea, both actually similar percentages on user fees. That respect, South Africa, Namibia, and some other countries are actually doing a lot better than us. It's since we have a social insurance scheme, it is also a wonder why we have so much, coming out of pocket spending. The ambition of the scheme is to precisely abolish that. Anyway, so that's some comparatives. But how's Ghana doing? So trends in health finance in Ghana. This just shows, this is total spending again. This is contrary to what I said. We have got here is total spending, it's not public spending. Current health spending as a percentage of GDP over the years. I just wanted to show that, here that we actually have not been doing well in recent years. Although it's current dollars, this is not real dollar, but nevertheless, it's an indication, because if you actually use real dollars, you find that it just tracks this, same pattern, but just simply that it will be prices slightly lower than this graph. And then, so you have, the precipitous fall, more or less off a cliff, in the more recent years, certainly after 2014. That has been noted elsewhere also in the financing picture in Ghana. So that's not a good one. And then if you use the same format as I just used for the African countries, you see that the domestic public has varied. There isn't a consistent trend from 2017. The trend is not really consistent. I mean, it started to rise. Domestic public started to rise after the NHIS Act, and then began to fall again, and hasn't really attained, at least in this charts anyway, hasn't attained its previous level yet, and the highest at this peak. So that's a cause for concern in terms of the trend and the available resources. We want to move this in a different direction. So the Ghana, what's the Ghana picture with respect to if you compare to if you use the same benchmarks that we just used for sub-Saharan Africa not long ago. So for the Abuja Declaration, we're at 6.1%. Okay. In terms of out-of-pocket spending, we're at 27% or less of total health spending. That actually is a figure that's lower. I've seen more recent figure to 36% actually. That was because of the so-called co-payments at health facilities that that we've all witnessed. After the NHIS started going into deficits. So actually the trend, even out-of-pocket spending, was not good. Meanwhile, actually at the beginning, when the NHIS was set up, a few years after that, the actual out-of-pocket spending dropped drastically to actually around 20%. So we were actually within the norm at some point, but that's not been the picture since. On the percentage of GDP, 3.3%, it's above the African average, but still not anywhere near percentage of GDP that a USC-seeking country ought to attain. And again, also similarly with the per capita spending, Switzerland is below what is suggested. And I said 86 is actually the barest minimum. It's just to buy an essential services package. It's not the kind of package that we have defined in the Ghanaian law for national insurance scheme, for instance. It will be much more expensive than even $86 per capita if we were trying talking about that. So this is, again, not a very good picture for us. But this is an interesting one. The government helps expenditure to MoH and NHIS. In the course of time, you find out that since 2010, at least according to this data, as time goes on, spending, the health spending is increasingly dominated by, increasingly, getting biased or, towards the NHIS, which is the orange here. So gradually that one is going to the detriment of other sector resources, which the Ministry of Health and others control, and therefore potentially reducing the amount that is available for, say, public health interventions, because public health interventions generally go through at least key ones go through the Ministry of Health as far as now. So this is interesting, but nevertheless, it should also be seen as an opportunity, because if the NHIS, because the NHIS is the only strategic purchaser in the Ghanaian system, is the only one that has a potential anyway to do strategic purchasing. So the more that resources are going there, the more that perhaps we should argue that the NHIS should begin to allocate its spending more strategically and to target the health priorities of the country and not just curative care, which is basically paying for the failures of the public health sector. We should actually be arguing that we are putting all these resources into the NHIS, the most stable source of funding, and it's growing, then it should be more aligned with the priorities of the country. That's at least the one interpretation that we can make of this, and a hopeful one, that to the extent that we can do that, and in fact, NHIS by its design is the one most amenable to arguments about strategic purchasing and efficient resource allocation, alignment with the health priorities and so on. So it seems to me that that is where our battle should be in order to ensure that the resources are released and cover public health interventions. We should be trying to get NHIS to reform its benefit package to include and cover, focus primarily on covering public health interventions that are currently not covered. But the NHIS does contribute to the Ministry of Health. It does send annually contribution to the Ministry of Health, which the Ministry of Health uses for some public health interventions and so on. So, that is that contribution, but that first of all, it isn't enough. Secondly, it isn't strategically used. So the NHIS is, as I said, the only strategic purchaser. And there are some key interventions that can be included in the NHIS benefit package without any strong quality, actually much more effectively and efficiently delivered through the NHIS platform, which are not being done. So that's one interpretation of this, and I think that we can see that's a good sign, not necessarily a bad thing. But the challenges that we face, the resource mobilization. The fiscal deficit, the Minister of Health has made that clear recently, that we have a fiscal deficit that makes it difficult to find new resources. And this has been aggravated by COVID, right? Then we have the NHIS, the NHIL, the levy is reliant on economic growth, but economic growth has been tanking recently, at least been going, has been going the wrong direction in terms of where it was before COVID. And so that's another challenge. Now, there's also the rigidity of the budget. The Minister of Health also said, I think around 2017, he said that the discretionary spending actually within the budget was very low. I think he said something like 7% only. Everything else is earmarked or pre-allocated. It goes to some fixed costs and spendings and so on. So that was cause of concern, leading to the 2017 Act, the capping of earmarked taxes, which was passed in order to constrain earmarked taxes, not all the pre-allocations, but the earmarked, certain earmarked taxes, which they had identified in the law, were not to exceed 25% of the budget. Now, at that time, those taxes that were mentioned were already altogether consuming 33% of the budget. That meant automatically that we're going to be a decrease in the revenue going to all of all the recipients of the earmarks, including the NHIS. So the NHIS, I remember that the previous CEO then actually stated the very first year after this law was passed that they actually got a hit on their income of if it was something like 100 million cedis, but I may be wrong in terms of my recollection, but I know that there was a hit on the NHIS income, which was concrete and which was measurable. So as a result of the capping, so the income for the NHIS was coming down. Other challenges is a complex landscape. You can see that on this side that there's a lot of fragmentation in the system. Now, at very least, it's not as bad as the what you call the spaghetti diagram that when I was working for another company, HLSP, we did we traced the allocations within and agencies within the health sector of Tanzania, and and the diagram that we came up with, I think was nicknamed the spaghetti diagram. It was so messy, and with lines crisscrossing everywhere, so on. So at least compared to that one, I mean, I have to say that this is a simpler one. Nevertheless, it isn't a picture that is well streamlined and shows how strategically we're actually using our monies. But we have this complex landscape and creates difficulties for tracking the flow of funds, for instance, maybe estimating the size of the gaps, the flow of the funds, from top to the bottom. fragmentation also affects PFM, public financial management. That is, lack of consistent and accurate resource tracking contribute to challenges with planning, coordination, and accountability to accounting for the use of the funds, and so on. But there are opportunities. There are some opportunities in the system. The same COVID pandemic that has devastated the economy has actually also brought high-level attention to the sector. For instance, the president himself, as we know, has been paying a lot of attention to the sector. Has many radio announcements, lots of meetings with people in the sector, has actually made more investments available to not just to support the pandemic, but also to support the sector as a whole. So there is also that opportunity. The pandemic has, in fact, also ironically brought this attention, which should be seized, and in fact, I know is being seized. So currently, for instance, I know the COVID response team is pivoting to focus on longer-term health systems and strengthening initiatives, and so that is a way in which this higher access to the decision makers in our country is being used, being translated into trying to support the long-term problems, resolve the long-term problems of the country. In fact, it's the first time I've seen a Minister of Health in Ghana actually write a blog on health. That's, the minister wrote a blog, I think it was in Financial Times, on his experience with the pandemic and, and so on. So that is a level which, by, given that all these years that I've been involved in the health sector in Ghana, we've been struggling very hard to get attention from the Ministry of Finance on health issues, invite them to meetings, so forth, try to engage. We've never got the kind of attention that we have now. So that's an opportunity I really want to stress that we shouldn't let pass, and try to turn it into advantage, so that some of the stubborn problems and obstacles in the sector that have not been resolved because they need high-level policymaker decisions to be able to move. This is the time, and I think that those who are working in these areas and have that access and so forth should really, do their best to take advantage of that. So my final slide. Sorry, I've taken so long and tested your patience. This is the final one, I promise you. So let's recall that the key issue is not just to raise resources broadly, right, but to ensure also that they are used most cost effectively. I think that if resources in our country are used most cost effectively, they would automatically benefit public health, because you can get better more cost effective interventions than the public health intervention. So that's where that's an aspect of the dimension of resource mobilization that I wanted to draw attention to. It's not just how to raise more money, it's also how to use it effectively, cost effectively. And some of that can happen through prioritization of primary healthcare, including prevention and promotion, as I've been trying to say, and then using global budgets to constrain the cost of secondary and tertiary care, and we've seen in the advanced countries, the examples that I showed. Use global budgets. That can then help you to maintain, to both focus primarily on the cost-effective interventions, but also not have a blowout situation at the secondary and tertiary levels. The NHIS review of 2016, some of you know that I was involved in that, showed that the NHIS benefit package wasn't fully aligned with our public health priorities. We found out that it was curative care focused, but the conditions that actually give rise to some of the diseases that the NHI was concerned with were not being tackled in the NHI's benefit package. So hence our recommendation that you should focus the NHI's funds primarily, though not exclusively, on a PAC for all strategy, including prevention and promotion. I want to thank Dr. Mofa here, and Adriana, who actually helped us very much during the review to actually spell out what that package would be like. That package that is focused on supporting and aligning, allocating the resources of the NHS to primarily focus on local interventions, including a PAC for all package. And as an actuarial study was actually done which I think showed that it's not a dream at all, and can actually be realized if there's a will to do it. So now, mobilizing resources for public health is for me, therefore, a two-pronged process. One is ensuring that the health sector gets its share of the national pie. This is just sort of really repeating something what the national budget prioritization, but then also ensuring that resources are obtained are allocated efficiently. That's, including public health interventions. Both of those battles are fought in the political economy sphere. Okay, so for the first one, learning to advocate for more resources from the Ministry of Health, Ministry of Finance, the crucial skill that I believe that ministries of health in Africa are largely still to master. I think there's a legacy of the era of swaps and direct support, even off-budget support from donors, where ministries of health didn't have to deal very much with advocacy, the Ministry of Finance for their resources. I think that that era is past. So now with direct budget support and so forth, and they really need to develop their skills well. And I actually see that all the time. I work in several countries in Africa, and I see that lack all the time because I can see the language. I mean, I was lucky enough to have at least been in situations where I could also see the point of view of the Ministry of Finance, and I see how they make decisions out. I mean, as an economist, obviously, I understand some of the factors. The Ministry of Finance, for instance, says, or Minister of Finance says, look, my priority is to grow the economy. And so, he wants to know, what's your contribution to economic growth? Then you go and say, we want to save lives, we want to, reduce this, disease here and there. That doesn't necessarily cut ice, unfortunately. It doesn't necessarily contribute. And as we saw, it is not really inconsistent with our objectives. When the Ministry of Finance says they want to grow the economy, actually, as we know, when the economy grows, we also benefit. Even if the share of health doesn't increase, the mere growth of the economy alone will actually bring more resources. That alone also increasing the share, the actual share. So there are two ways in which a growing economy can benefit the health sector. So if we can begin with that agreement, that sense that we are actually on the same, we have the same objectives, that we want to do the same. Then we should do more to show how the health sector is contributing to economic growth. So well, this is something that's not well done. If you look at how the GDP is calculated, the health sector's contribution is just in the buildings and whatnot that are there. There's no calculation of what the benefits of curing people and so forth is to economic growth. That's not part of the GDP calculation. So, these are some of the things. I mean, I remind the starkly of an example of Kenya, where around 2006, the Ministry of Health led a process and really championed a new universal health coverage package and a bill that actually was passed in Parliament, overwhelmingly in Parliament, to introduce a new universal health coverage scheme. Really much better than what the NHIS that they have now. And the Minister of Finance, at the day after the bill was passed, went on television to denounce the bill. He said, this is not affordable, this is irresponsible, and so forth. And the president actually vetoed the bill. That's a sign of how the Ministry of Health just simply was out of whack with the Ministry of Finance. They actually didn't do their work well. I think it's very important to learn from here. And then for the second one, in terms of ensuring that resources are allocated efficiently, which will benefit public health. Well, I don't have a better example than to say that this very event, put forward by the Ghana Public Health Association, is a skirmish in that battle in itself. And I think that we should congratulate the Ghana Public Health Association for doing our best to try and draw public attention to the issues and the problems of financing for public health, which I think hopefully this is a contribution to. Thank you all very much. Just stop here and hopefully hear some comments and questions and so on. But thanks a lot.
Thank you very much, sir. That was a very insightful and very comprehensive presentation on domestic mobilization of resources for public health. Usually when I sit in a presentation, I already I list my questions, and as the presenter speaks, I cancel a few of them out, and the outstanding ones are usually the questions I would like to ask. But as you presented, I ended up canceling everything. That is to say that the presentation has been really, really insightful. We are very grateful for this particular support. I would now we still have some 15 minutes to end the session. So I would now open the floor for questions. But I have seen some people drop some questions in the chat box. So Dr. Chris Atim, if you don't mind, I can start with those ones.
Sure.
Yes. So I'm going to merge some of them together because they seem to be asking similar questions. I think that most people got excited about the graph that showed the trend of expenditure for Ghana. And they are wondering what you think, yes, this particular one. They are wondering what you think is the cause of the dwindling trend in the last few years. And someone went ahead to ask whether you think it is as a result of the IMF bailout. So probably we need you to throw a little bit of insight on some contextual factors that you think might be I know you mentioned a few of them, but in summary, some of the reasons why we are seeing this drop.
Yeah.
The second one is about the role of domestic private foundations and non-governmental organizations in resource mobilization. So I think you can take these two for now. Thank you.
Sorry, what is the second one?
What is the role of domestic private foundations and non-governmental organizations in resource mobilization for public health? Thank you.
Okay, yeah, thank you. Okay, thank you. Okay, so yes, no, that I agree that this graph is very striking. When I first saw it myself, and when people presented it to me, some we used this before some time ago, I was amazed. But then, if you look at it well, so this is one of the things that the argument people make about earmark funding. See, the earmark funding, as we have for the Ghana National Health Insurance Scheme, is good because actually it assures a stable source of funding, predictable in whatever it is in the future, as long as you can predict the economic growth trends, and so you can predict how much money you're going to get, so on. So it's good, and we should maintain it. I definitely don't want to argue against it, but I want to point out disadvantages to it, because ministries of finance don't like earmark funding. They hate it. Here, President Kufuor put pressure on them. They actually agreed. At the time, in fact, the reason they did it was also, there was a political reason also. The 2.5% VAT was actually a way to get around the fact that IMF wanted to see a 2.5% VAT increase, which when the Rawlings government tried to do it, could not, because of public demonstrations, which were indeed actually even led by the government, the then government, the government that took over. And so they had a difficulty with that, trying to, implement the same policy that they had, opposed when in opposition. And one of the ways in which they did that, which was very clever, and it did not come from the Ministry of Health, by the way. It wasn't the Ministry of Health, it was the economic management team at the time that actually proposed the judgments and others who proposed that the way to do that was to actually set it up as an earmark for health. They have seen the example of the earmark for education, 2.5%, which was successful. So an earmark for health, especially to meet the campaign promise, was a no-brainer. So that's why it was set up. But the thing is that then almost soon after that, the Ministry of Finance began to actually almost encroach on this and to erode the effects of it by decreasing the other funding to the sector. This is well known to people in the sector, actually. I think especially GHS, you would know that, utilities and whatnot, capital expenditure, there are years where capital expenditure was zero. They actually really reduced drastically the funding in the other areas. So there was a substitution effect, there. And that is one reason. I'm not saying it's the only one, but certainly it's one apparent and glaring one to me of why we're going to see this decline. There was also the economic situation, the economic decline. The growth in the economy was lower. The general trend was not as positive in the period of this decline. It began to, actually in the last couple of years, it began to rise again. We don't have that. but I think it began to rise because the government was beginning to actually allocate more resources, especially to NHIS, but not to replace the other the funds that were taken away. And the other thing was that when they capped the funding, then that also began to negate the effects of the increased allocation to NHIS. So there are complex of factors, there. So that's the picture, I think, as far as this decline is concerned. And so it's like, beware what you wish for, in effect, because, you wish for an earmarked fund, and then Ministry of Finance said, well, we give to you, but we'll take it with the other hand. We'll take it back from with the other hand. In terms of the domestic private foundations and NGOs, their role in the resource mobilization, I think that they absolutely, we don't have enough of that. Obviously, we don't want, the private foundations, if they are able to complement some funding, in particular cases, I think that is always welcome. Now, no one should, be against that. I think that they have an important role. I mean, we've seen that some of them can actually help, especially with building facilities and so on. Some of them have a capacity to do that. And I think that is more appropriate even than recurrent funding. We don't want private foundations to be paying for recurrent costs, things that, okay, annually, because that's not sustainable. But if they can contribute to investment costs, equipment and things like that, are durable, that would be fantastic. That's actually a role that's appropriate for them. NGOs, in my view, can also help with actually raising awareness and actually lobbying, ensuring that the problems of the sector are in front of the public. And I think that, for instance, the kind of thing that the Ghana Public Health Association is doing, if you're doing it in alliance with other organizations, NGOs, for instance, I think their voice will be more powerful. NGOs, I know some NGOs that actually are working in this area too, reproductive health and so on. I think that they don't get enough attention. I think that those who are working in the sector and the public health sphere can actually form alliances with all these other NGOs to try and push for a common agenda. And especially in the current context, as I say, the pandemic has brought this attention to the issues of the sector to actually ensure that the investment is done right. Because we should say, if you are going to have more money for the sector, these are the areas in which you ought to do to invest in order for us to get the best bang for our buck. That's something that NGOs are very well qualified to do. They have access to media. They can actually, and to parliament and so forth. They can actually make, a sizable contribution. So I think that's how I would see their roles. I mean, obviously these are not exhaustive, and others may also have some suggestions, but these are the ones that I see.
Thank you very much, sir. Yes, please. Thank you so much, sir. So our time is almost up, but the demand is still high. So I think that we would add a little bit of supply since we are talking about financing. So right. I just want to give you the two last questions, just briefly, if you have something to say on them. There's a question about, in your opinion, whether you think that the NHIS is sustainable with the domestic funding strategies. And the second one is that despite the dwindling funding in Ghana, what are some of the international opportunities that we have to increase funding for public health intervention? So this will be the last two. We will not take any extra. And we will also give your details out for those who are still pumping in a lot of questions to contact you later. So say if you could quickly, yes, please.
No, that's fine. Yeah, okay, thank you. Yeah, whether the NHIS is sustainable with domestic resource mobilization strategies, I'm an optimist, and I have to say yes, it is sustainable, provided certain reforms are made. That it has to be conditioned. It is sustainable, and I think that one of the prides that we have as Ghanaians is the fact that NHIS was always designed to be a wholly indigenous funded, fully Ghanaian, as it were. Well, yeah, at the beginning anyway, certainly fully Ghanaian funded organization. Of course, in the course of time, it has they've got funds, and support from other sources, but those have always been very small compared to what comes from the internal sources, and we should be proud of that. We really should not want the NHIS should become predominantly dependent upon external sources. In any case, it's against the current zeitgeist, the international development. Everything is now about domestic resource mobilization, and we should religiously emphasize that. I think it is sustainable, but it requires some reforms. And the reforms specifically are in strategic purchasing and actually the focusing the resources on aligning them with the health priorities of the country. I think that if those reforms are made, it is sustainable. So that's my answer to that one. And then what are international opportunities? Well, yes, the international climate is not as favorable as it used to be. But if you ask me for what opportunities there are still the international initiatives, the Gavi, Global Fund, the private foundations internationally, and where we need to engage with them. And I think that I'm not for autarkic development. I think that there are things that you can do even when it's tiny amount of support from some of these organizations. It can make a big difference, but we just need to to actually direct it appropriately. So I'm not in favor of international opportunities for supporting recurrent expenditures in Ghana. I think we should really do everything to fund our recurrent spending, but there are opportunities for supporting targeted reform. For instance, even the restructuring of the NHIS funds I'm talking about, international experience to bear. Learning what the Asians did. Asians actually are the most relevant example for us today, I think, than any other countries, not even Europe. I think it's Asia, to be honest. That's really the example. But we are far from Asia. We don't have the same kind of connections with Asia as we have with Europe, for instance, and America. I think that opportunities to actually learn from the Asian countries and how they manage to do what they have done would be, enormously helpful. So, and as I said, opportunities exist at those international initiatives as well as the private foundations that are willing and actually investing in areas that are very germane to our our priorities as well, in terms of capacity building and maybe some capital investments that are not huge but actually make a big difference. I think those are the opportunities I would stress. Thank you. Thanks, Dr. Ashino.
Thank you so very much, sir. So ladies and gentlemen, you've been listening to Dr. Chris Atim, who is a Senior Program Director at Results for Development Institute here in Accra, Ghana. And he is also the Founding Executive Director of the African Health Economics and Policy Association. He has been very, very instrumental this evening, giving us a very comprehensive presentation. He started by highlighting how low there is spending per capita in lower middle income countries in sub-Saharan Africa. And then he also demonstrated that this underfunding has the tendency to drive other forms of funding, particularly international initiatives, user fees, and there's a need to move from the out-of-pocket payments towards UHC, which is the main reason why we are actually discussing how to mobilize funding. I was particularly happy about the two-pronged approach, which our resource person highlighted, that we shouldn't only focus on mobilizing domestic resources. We should also look at how efficiently we are using these resources, which is really the most important thing in resource-constrained settings such as Ghana. And I think that is a very key takeaway message for us. Despite the cry about COVID-19 and how funding is going into the health system, I think he has also highlighted opportunities that COVID-19 brings and how we can maximize those as well towards universal health coverage. Finally, I want to acknowledge our president, Dr. Georgia Mofa, who joined us during the session. And since we are talking about health financing and mobilizing resources, I also want to acknowledge our NHIA boss, Dr. Selby. She's been with us throughout the presentation. We want to thank her and all senior colleagues who joined the discussion this evening. At this point, I want to hand over to James to take it up from there. Thank you all. And sir, thank you so much for the presentation once again. Good.
Thank you so much. Thanks for your able chairmanship.
Thank you very much, Dr. Ashinia.
Thank you. I like the womanship component.
Okay, before we end, Dr. Mofa, please, you can speak to us now.
Yes, thank you very much. And shall we give Doc a hand? I mean, whatever you are, wave to him for accepting to give the presentation at a very short notice. In fact, it was through the instrumentality of my sister, Dr. Mercy Ahun, who I'm sure cajoled him to accept our invitation. But I've known Chris for some time. We had a few banters some years, a few years back when we were pushing for public health interventions to be funded by the NHIS. We met him and his team to defend our case. I knew he was aware of it, and in heart he was definitely in support of what we're pushing. But for the consultancy's sake, I'm sure he was being cautious in accepting it. But and so, Doc, we want to thank you so much. We want to assure all public health practitioners that this is the type of thing we want. In fact, we will be, in terms of our advocacy action, we will be pooling local resources to make diverse presentations on different aspects of health and the health system. And not only make the presentation, but usually we follow up behind the scenes to ensure that the things are moving on nicely. In the course of the month, in November, it's likely we will have our last virtual meeting for the year. I think we've done very well. In fact, even before COVID, when we were doing in-person presentations, we were only able to do about 3 a year. And now we are already on 4, even though we didn't even start early. And so we want to build the momentum, and we encourage all of you to be part of it. So thank you so much. And thank, I recognize Professor Ofureje, our former president, also on the line, and Dr. Nana Enimayo. I came a little late, so I couldn't get everybody, but you are all welcome, and thank for your participation.
Thank you very much. So Dr. Mofa is the president of the Ghana Public Health Association. And to also say that for those of us who are not members of Ghana Public Health Association, can also get in touch with us so we can get you the membership form so you can be part of us. This is a great body. We want everybody to be on board so we can continue our advocacy and ensure that the right thing is done in this country. So thank you so much for joining, all of you, and have a good night. Thank you very much.